Hey, this is Sandy.
And Randy.
And we're here on AT Corner.
Being an athletic trainer comes with ups and downs, and we're here to showcase them all.
Join us as we share our world in sports medicine.
Welcome back to another episode of AT Corner. For this week's episode, we are going back to the surgery series with an exciting interview on Achilles tendon repair.
And not only do we have one physician, but for this episode, we actually have two, which is actually really cool.
Yeah, we actually haven't had two people for an interview at the same time in a very long time, it feels like.
Yeah, it's been a while. I think the last one was also from UCI, if I'm remembering.
Ooh, I think you're right, yeah. Yeah, UCI treating us well.
Yeah, so you want to introduce our docs today?
Yes, so Dr. Brandon Haghverdian completed his undergrad, med school, and orthopedic surgery residency at UC Irvine. He completed his fellowship in foot and ankle surgery at UC Davis Reno Orthopedic Clinic. Dr. Brandon Haghverdian completed his undergrad and med school at UCI as well. And he completed his ortho residency at University of Pennsylvania. He also completed his foot and ankle fellowship at Duke University.
I think it was really cool to hear both perspectives as we talked to both brothers about what they each individually do for Achilles rupture, and then also considerations you have to take for the surgical procedure and rehabilitation.
Mm-hmm. Yeah, for sure.
So without further ado, let's hear from the docs. Do you want to get us started?
Yes, so at AT Corner, we really like to pair that evidence with experience. So if we can kick this story or this episode off with a story about treating an athlete with an Achilles tendon rupture.
Yeah, I'll go first and kind of give you an interesting case that happened for me. So this was the very first patient I treated with an Achilles tendon rupture in my practice. And it was actually my first day of practice. And, of course, you're trying to figure out on your first day where the bathrooms are. You're trying to figure out how to get your hospital badge. You're not really expecting an NFL kicker to come and see you on your first day of practice with an acute Achilles tendon rupture. And you have a really long discussion. You kind of know what to say, but this is my first experience in treating a rupture, solo. And this is an injury that can affect people's both livelihood, their careers. It can affect their recreation, what they like to do for fun, and just their every day. And so for this gentleman, even though he was kind of a journeyman kicker, he was still interested in still playing in the NFL, and it introduced a lot of anxiety for me. And quite honestly, it was not long before I think he sensed that anxiety and took that as his cue to maybe see a second opinion before he went ahead with surgery with me. But I think it illustrates a lot of the challenges with this type of injury pattern. Both from our end and from the patient's end. We don't have a lot of consensus guidelines in orthopedic foot and ankle surgery, and we actually do have one on Achilles tendon ruptures, and it basically says, well, if you fix it, that's great, but it's probably similar outcomes compared to non-surgical treatment. And that leaves us really in a limbo in terms of indicating patients for surgery or not. And so that reflects in a lot of the conversations I have, and I'm sure we'll touch on some of those topics during this podcast. But, I think it just that kind of instance really illustrates how challenging this is for us to treat. I'm sure Justin agrees. It's a really kind of sore point in my practice, having that conversation for a lot of patients and really making the right decision for them.
And I'd have to say that, it's not as straightforward to what Brandon was alluding to as, say, a broken bone in an adult, which has a very straightforward answer, a treatment, and the answer is going to be surgery most of the time, right? Whereas with something like an Achilles tendon rupture, with all the literature that's out there, with it being so mixed, that there's going to be certain patients that may not benefit from surgery or may benefit from surgery. So having that dialogue with the patient to figure out and to kind of size them up and figure out what it is and, tailor that treatment plan to them, that's really kind of what makes Achilles tendon rupture specifically very nuanced and kind of, like he was alluding to, very difficult sometimes.
I was going to say, after that story, did that make you excited to treat more, or was that kind of like, okay, I think
No, I was excited from the get-go. It would have been a real accolade if my very first surgery in practice was an NFL athlete. But I think I'm always excited to treat Achilles ruptures. I just think it's one of the more interesting pathologies we treat because we don't always have an answer. Sometimes, like Justin said, it's really easy to see a patient, and sometimes you almost think you can just click a hologram and have that talk to the patient. But in this instance, you really have to delve deep with the patient. So that's kind of an exciting part of our jobs when we get to do that.
I think that's interesting that there's really no clear consensus on kind of that best course, like ACL, right? Especially for active populations, it tends to be, well, the best kind of practice is reconstruction. So that's crazy to hear that.
Yeah, and it's not common that we have that challenge, especially with an injury. Surely with elective, problems and diagnoses, we can have that conversation. But with a sudden tendon rupture, especially a tendon as critical as the Achilles, it's certainly the case that the Achilles can heal without surgery. It almost universally does. The question is, will it heal as strong and as powerful for that patient and for their specific needs? And that's where it really becomes an individual decision. But I tell patients all the time, the Achilles tendon heals. I have never gone in there in kind of a more chronic setting of an Achilles rupture, and I've seen nothing. I've seen a huge gap. That doesn't really happen. The tissue fills in very quickly. It's just the post-op and post-injury rehabilitation that's critical in terms of remodeling that tendon into a functional unit that's going to be, serve the strong functions that the Achilles tendon does.
So I think that actually brings to the point of early recognition of an Achilles tendon rupture is perhaps the most critical facet of Achilles tendon ruptures, is to actually not necessarily to say whether you need surgery or not, but actually getting them with what is considered the standard of care today versus say, a few decades ago. We are now promoting early functional rehabilitation. And so for that, when you start to really look at the literature and compare between surgery and no surgery, it does come down to like, who is the patient and what are their exact needs? And, do they need propulsive strength in their career or whatever it may be, if that's an athletic thing or in their job, or even if it's for recreation? I mean, we're having that discussion. But like Brandon said, the tendon does heal. It's when it is missed and not appropriately treated that we are seeing the outcomes of that, and they're generally poor. So early recognition, that comes down to just like urgent cares and emergency departments, just early or even on the field, whatever it may be, even, high school, which is less common than, adults. The average person is going to be like a 40-year-old male playing basketball, as a record on the weekend. But these injuries happen all the time. It's a very common, injury that we do see. It's just that when it's not treated appropriately is when we're dealing kind of with the consequences of, hey, you could have done the early functional rehabilitation and just done the appropriate physical therapy and probably been okay versus the surgery. But if you don't even get that opportunity, then that's when there are problems in the future.
For the patient that might be looking at more conservative, what have you seen that might be someone that could probably forego the surgery and maybe do the conservative? Like, what are some things you kind of look for in that?
Yeah, for me, I think there are some, I wouldn't call them absolute contraindications, but they definitely push me to non-operative treatment. So I think first and foremost, a patient who is a smoker or a heavy nicotine user, they are not people in my mind for whom an open incision in the back of the ankle, no matter how minimally invasive, is worth the risk of potentially losing your limb. So anybody who smokes, I generally treat non-operatively. An uncontrolled diabetic in that same sense, they'll likely get non-operative treatment in my hands. And then everybody over the age of 50 likes to think they're the most active individual on the planet, but the reality is our functional expectations certainly go down as as time goes on. And while I don't have a strict age requirement, I start to think if you're over 50, is it really worth it? I tell patients anecdotally, if I tore my Achilles tendon, I'm 35, I would likely treat it non-operatively, despite kind of my interest in sports and recreation. So there's certainly, no age cutoff, but it's one consideration for sure.
I have very similar kind of indications, or at least contraindications. I just generally have a very long discussion with the patient. A lot of the times patients will come in and they'll kind of have a preconceived notion. And it's just my job to go through that and kind of either educate and inform. And then if they are leaning more towards surgery, I just give them, this is what surgery looks like. Here are the risks. And they're very real risks. And you have to have that discussion and actually tell them about, this is an incision. There's general anesthesia. You're positioned prone. For most people are doing it that way. So it's definitely, there are some challenges associated with that. And then if you don't do surgery, you basically have none of those risks, right? Perhaps with the exception of a deep vein thrombosis, which is in both populations. So we generally provide some treatment for that or prophylaxis for that anyway, regardless of what whether you're having surgery or not. But for how I indicate patients is basically what do they like to do? What is their job? And what is their preference? And I'm basically show them that, hey, the rehabilitation between the two is almost identical. Our studies show that at a year, outcomes are very similar, with the exception of like a subset of population, particularly that being like high level athletes. So in that case, with high level athletes, I think the conversation is changing, at least in my hands as well, to more toward a surgical intervention. And I think Brandon would agree with that too.
So speaking of that surgical intervention for specifically an athlete, and I know it's hard to put a blanket statement on it, but how long should we be expecting for a recovery, and how quickly that athlete should be recovering through a surgical option?
Yeah, I think much like ACL reconstructions, this is a long-term rehabilitation. This is not one where you can expect to return to play within 2 or 3 months. The tendon doesn't remodel quickly enough to allow for that. And when I say remodel, like I said, that tendon tissue fills in pretty quickly, but it does not form the thick linear collagen fibers that can sustain functional contraction, especially with explosive movements like elite athletes or even recreational athletes often experience. So the timeline, I tell patients, expect a year before you're back to kind of your normal level of function. It's very common for people who tear their Achilles tendons to kind of forget which one they tore 5 years after their injury. But it can take that long to really overcome the post-traumatic stress that comes from an Achilles tendon rupture. But before you feel back to quote unquote normal and you're back to your regular level of recreation, I really tell patients expect up to a year of kind of this functional rehabilitation.
Yeah, I would echo the same. I lay it all out right there in the beginning on the first time, just because it's such a lengthy, prolonged rehabilitation. That look, this is going to take a year. I mean, we're making baby steps in the beginning. I mean, we're talking about walking, returning back to normal around 3-ish months, and then kind of start building up more of your strength in somewhere between that 3 to 6 and even longer than that. So to expect to come back to like pre-injury level, if that's even possible for certain people, that's going to be definitely at that year plus timeline.
And for some sort of reference, I tell patients at 6 months, if you're able to do a single limb heel rise, I'm proud and happy. Generally younger patients are able to get there a little bit faster, but it can take some patients really that long to get back to that. And people are shocked by that because oftentimes people can do unlimited single limb heel rises, especially in the kind of athletic populations that get Achilles tendon ruptures. So it's really kind of disheartening. And that's where our job after the injury, I'm sure your job as well, really becomes sort of cheerleading. It's about being patient and really kind of going through the motions every day to work on getting the ankle stronger. It doesn't happen suddenly. It's really stepwise.
Yeah, the baby step pun doesn't get old.
Yeah,
Yeah.
athletes don't like to hear that one very much.
No.
Yeah, no, this one is not. This is one that every athlete dreads,
For sure.
for obvious reasons.
For the actual surgery, what is a more common technique that's used to repair the tendon, or maybe what's a technique that you guys prefer?
Go ahead, Jeff.
Yeah, for the traditional type of technique for Achilles tendon rupture, like repair, is you would make an incision over the back of the Achilles, and then you would basically repair those ends end to end. And so that's usually done through some sort of non-absorbable suture material. And there's a variety of different techniques and methods on how you actually lock the suture material together. There's been kind of a push and an advancement in kind of how we approach them now, where there's more percutaneous or like small type of minimally invasive methods. That's the one that I tend to use, unless it's a different type of Achilles tendon rupture, like a more chronic one. But for the most mid-substance acute, Achilles tendon ruptures, I'm doing a minimally invasive type of technique, and I just prefer to limit the incision size. And the way that I do it is I tend to grab the proximal end of the rupture and then bypass the actual rupture site and then dock it into the calcaneus. And that's a more common type of method that's being employed now. But some people just choose to do end to end, and there's a lot of different ways to do it. And I've seen it done many different ways with very good outcomes. It's just kind of like what is your preference? What's your familiarity with the techniques and kind of that thing, and what do you like to do? That's probably the technique that you should use if you are you're the one doing the surgery. But for patients, they just want their Achilles repaired. Some of them come in asking specifically for which kind of method that you're going to use, and for the most part, I think that they do like the minimally invasive. I've had very good, at least reduction in wound related complications, which is can be horrific in that area specifically.
Yeah, wounds in the back of the ankle are something we as surgeons really dread. It can be really challenging to kind of backtrack from a wound that's broken down in the back of the heel. I think the only caveat I kind of add to that is, one of the first things we do to assess Achilles ruptures is to assess the location. So we've been talking a lot about non-operative, operative treatment. I would really emphasize that this is applying to mid-substance Achilles ruptures, in the classic kind of 2 to 6 centimeters proximal to the insertion, watershed zone. But for insertional Achilles ruptures, the management is almost always surgical. And that technique in terms of repairing the Achilles is more of a reconstruction back down from the insertion point of the Achilles down to the calcaneus, typically using suture anchors. And that's oftentimes done through an open approach. So I think most of this conversation is going to kind of deal with mid-substance ruptures. But I think it's important for any practitioner kind of diagnosing them, because they can present very similarly, to really understand that there are two different pathologies managed very differently.
Does it change at all if you know someone has a history of a tendinopathy?
Not necessarily. It just back to kind of the location of it. If their tendinopathy preceded their like distal Achilles tendon rupture, then that is good history information. But the key is going to be the physical examination. And usually on an X-ray, you'll be able to see some indication that there was a distal rupture. Usually you'll see kind of that bone spur, that enthesophyte that actually has avulsed off. That's by far the biggest indication, but obviously a physical examination. Overwhelmingly, I find that diagnosing an Achilles tendon rupture is not as challenging, especially if you've seen a bunch of them, but it can be with the swelling and that kind of stuff. But there's a very palpable, gap that occurs in the tendon, and it's not subtle. Like the contour of the tendon is missing. It does not look like the other side. And then, they obviously have other findings, like they're not able to, when you squeeze their calf, their heel, their foot doesn't plantar flex. So there are these clinical indications, but you need to have a high alert for a distal rupture because, like, Brandon was saying, this is surgical. So they are much more rare. So obviously having your, you just got to be on alert for just knowing that it exists. But to your question, a lot of people do have some sort of preceding kind of like tendinopathy, different types, but how that factors into how I treat them, it doesn't, because I just basically present them with the same options anyway. And it's either going to be surgery or it's going to be that early functional rehab.
Would it also change if it was a partial tear versus a full rupture?
Yeah, absolutely. In my hands, a partial tear we can typically treat very well without surgery. Oftentimes, that's indicated by a more kind of intact Thompson's test, like Justin was just alluding to. You'll see some motion with squeezing the calf. It may not be nearly what is present on the other side. In those instances, I do get an MRI. I like to see some straining of the tendon, some bridging fibers between the ends. To encourage me not to operate if that's the case. But, often if you see 99% of the tendon ruptured and you only see a few fibers, I think the conversation really does revert back to kind of that non-operative versus operative discussion. An MRI can guide you in that, but it's still goes back to having a discussion with the patient.
I feel like we've already kind of touched on a lot of this, but is there any additional kind of education that you like to give the patient before they're going into that Achilles repair?
I give them basically, I tell them that it's going to be, there's obviously the psychology behind it, kind of prepping them for the long rehab. That's the first start. And then I kind of, liken it to when I talk to them about the rehabilitation, I set expectations very early on about the rehabilitation, because if you take someone who's like in the peak shape of their life, and these are professional, athletes, and it takes them, this is definitely season ending, if not sometimes career ending. And it takes them a year to come back, and sometimes not to a pre-injury level. Like, these are people who have a lot of resources behind them, and it's just a very difficult rehabilitation. So once you set that expectation, then it's talking about the actual surgery. Like, let's say they do choose to undergo that. I talk about the general anesthesia. I talk about the wound. That's by far one of the biggest ones, is wound related complications. And then I talk a little bit more about kind of the specifics of the type of the surgery that I do, which is the minimally invasive surgery carries a risk of having a specific type of nerve injury associated with it. So I'm counseling patients on that beforehand, and then talking about what the most important thing is regardless of what I do, is going to be adherence to the rehabilitation and really physical therapy afterwards. Like, that's going to be the key.
Yeah, totally agreed. I think the only thing I would add, and it may not be the conversation you have right away, it may not be the conversation you have in the first 2 to 3 months, but at some point, in the length of their rehab, you have to have a conversation about returning to the activity or the sports that caused the injury. If you're somebody in your 50s who occasionally plays basketball and you tore your Achilles tendon playing basketball, even though you may really enjoy that sport, you have to question if it's worth it to risk a re-rupture or risk a rupture on the other side. Because if you've had a rupture on one side, you're certainly at risk for rupturing the other side. I don't tell anybody they have to stop playing a specific sport, but there are certain high-risk sports we know can elevate your risk of rupturing your tendon. Basketball, football, any sport that involves sudden acceleration, deceleration, or explosive movements, you're at high risk. So if you can choose a lower impact sport or a sport that doesn't involve those motions, you can really protect yourself from re-injury. So it's a long-winded way of saying I really have to have a conversation telling patients, is it really worth it to go back to playing basketball? It's a tough conversation to have sometimes.
Oh, I can imagine, for sure. Absolutely.
So for someone who is going to undergo an Achilles repair, what are some things that we as athletic trainers can do to help prepare them, whether that be physically, emotionally, all of the above?
Yeah, I mean, I think emotionally, for sure. Yeah, I think if you're going to have, especially with the population you're working with, for an athlete, it can be devastating mentally. So, but with the newer techniques and the rehabilitation protocols that have really they have changed the game when it comes to recovering from an Achilles tendon rupture, especially in the young or maybe the younger athlete. That is basically it's a difficult course, but it can be overcome through a lot of diligence. Things to prepare them for, I would say, is primarily that. It's not the same, I would say, in terms of like an ACL reconstruction where there's a specific type of like prehab or something like that, because with an Achilles tendon rupture, we're actually treating them pretty acutely. So most of the time it just has to do with making sure that they're appropriately diagnosed, get them immobilized, whether that be through a splint, cast, or a type of boot with heel wedges. The biggest thing is trying to first get that tendon shortened, so that at the time of our surgery, we can get the ends as close together as possible. That's kind of our goal, is to restore that length tension relationship. But that's, we're going to be treating these relatively soon from the time that we even hear about it. So most of the time it's going to be within like 2 weeks of the first time that we hear about it. And there's actually some more recent literature to support even operating earlier. But I would say not necessarily from like a physical standpoint, aside from, making sure that they're appropriately immobilized.
Actually, that kind of brings up a good point. I know in the past I've had, when I've had an Achilles rupture, I've put them in a plantar flex position in a boot with crutches. Is there a better way, or do you prefer some method of immobilization? One versus the other, or both, or something else?
I think if you're planning to get to surgery pretty quickly, or you have that ability, I don't know that it makes the world's biggest difference to be in a plantar flex boot or a plantar flex splint, plantar flex cast. I think those are all reasonable options. The tendon's not all of a sudden going to scar in that quickly, but if it's going to take a little bit longer, 2-3 weeks, I always like to start patients off in a more rigid splint or a cast. I think the benefit there, especially if you're referring to somebody for a surgical discussion, that patient may opt for non-operative treatment after that discussion, even in an athletic population. I would say my rate of treating Achilles tendon ruptures non-operatively is about 50%. You've gained the benefit of, you can start that patient in functional rehab right away. Whereas if they've been in a boot that they've been taking off, multiple times a day, that tendon's been lengthening. So I think the benefit again is if you put them in a splint, that tendon's been in a shortened position, the gap has been shortened. If they've been in that for a week before I've seen them, then I can say, okay, well, just pretty much just 1 more week to go and we can get you weight bearing in a boot right away.
So we've talked about like surgery being fairly quickly, or at least in an acute setting, it tends to be fairly quickly. Is there a preferred time frame that you would like to have them start surgery? I've had one where we pretty much had surgery same day to like maybe 2 days later. Is there like a preferred time frame?
Most of the time it's going to be done within like a week or two, I would say, just by constraints of the system. Definitely it's not unheard of to be done either same day or within like 48 hours. That's common as well. It just kind of depends on the schedule. I think it is preferred if you are saying like, I know I want to have surgery. Right. Getting that tendon, the length tension restored, at least getting it done within the first week or two is much better than, say, waiting like 3, 4, or 5 weeks. At that point, you start to convert into like a more chronic type of situation, and that's a completely different type of treatment. So at that point, like Brandon was saying, that getting that tendon opposed or as close together as possible is going to give them the best shot to eat, regardless of which way they go. So I think that treating it sooner rather than later is probably going to be the answer. And like I said, I alluded to this earlier, but there's actually some recent evidence to support that some people may do better if fixed earlier.
So kind of on the opposite end, is there anything that we should avoid having them do?
I think that there are a few time points where a risk of a complication is higher. I would say within the first 6 weeks, there's a risk of over elongation. We know even with surgery that the tendon will elongate. Our repair will fail to some degree. And that's okay. That's kind of built into our surgical technique, is to account for some degree of elongation during the immediate kind of post-op. I think it's the key thing to avoid is aggressive stretching early on. I think that's kind of a goal, because sometimes patients come out and their foot's pointed 40 degrees to the ground, and that can be worrisome to some people.
Yeah.
But that's kind of a goal with my surgery, is I'm trying to get it as tight as possible, acknowledging that we can get the tendon looser. It's hard to get it tighter after the surgery. So I think my restriction is no dorsiflexion of the ankle past neutral for the first 8 weeks. And oftentimes I really encourage the patient to make that only active range of motion. I think it's easy to have a family member or a therapist kind of push on the ankle, and it's can be pretty easy to elongate it early, which just means weakness later on. I think the other concerning time points, at least from my standpoint and from a rehab standpoint, is the transition from boot to shoes. I typically try to transition with a heel lift, but that's oftentimes, in my experience, being the time where patients re-rupture. Oftentimes the pain's gone away, they have a little bit more motion back, they feel comfortable weight bearing. And so sometimes to no fault of their own, but sometimes patients kind of overdo it, either with walking or with specific movements. And they'll all of a sudden feel a pop in their ankle. And you kind of know at that point that there's been a re-rupture that may kind of backtrack the rehab a little bit.
Is there anything else that the athletic trainer should focus on when they're doing the rehabilitation for someone that is post-repair?
I think, what phase they're kind of in their recovery, it really depends. Like if they're, in the immediate post-op, then we're basically just trying to protect the repair and do everything possible, and then just kind of slowly reintroduce kind of strengthening. Once we've kind of regained our mobility, then we can start to introduce strengthening, but that happens over months, right? So most will have some sort of set guideline in terms of like, what do you do from 0 to 2, 2 to 6, 6 to 12, and then they're on, So in the beginning phases, I think that there are some critical points. So kind of avoiding that passive, trying to get more motion early on. Whereas we do know it can be frustrating. When you have an athlete who's like, it just feels really tight, and that may be contributing to some pain. We do find that in the long term that it loosens up. So we do know that most people will get their motion back over some time. So at least allowing that tendon to reconstitute and get that strength back while it's actually in the correct length is going to be very beneficial to get back their propulsive strength. That was the whole point of doing the surgery to begin with. So I think that that's one area to focus on, is kind of that early repair to protect the tendon, and then having that return to play discussion is kind of a controversial one, but there are certain metrics and things that different types of things people like to use. Limb symmetry is going to be probably the biggest one to decide whether or not that someone is ready to go back to play. But for me, it's going to be a time thing as well.
Yeah, I think the only thing I would add is there's been a number of kind of functional rehabilitation protocols that have been published, and certainly it's been a panacea in terms of allowing patients to recover from Achilles tendon ruptures over the last 20, 30 years. Prior to that, we were casting ruptures for 6 or 8 weeks after the injury, and that resulted in an ankle that was stiff, weak, and hard to rehab. Thankfully, we have a number of these rehab protocols. I think the key thing, though, is recognizing that patients aren't calendars, and everybody kind of recovers at their own pace. So even if somebody's a little bit slower, that doesn't mean they won't get to that point. We don't have to push things. I think after week 8, the risk of a re-rupture is much lower. We can do a little bit more and become a little bit more aggressive with therapy. But I have some patients, they're showing up at 9 or 12 months post-op or post-rehab, post-injury, and they're still not able to do a single limb heel rise. Again, it's about reassuring the patient that that's okay. They will recover, they will get better. If not, we also have surgical treatment options to get them that added strength. But recognizing that it's a 1 year recovery, maybe even for some patients a little bit longer. There's no rush. You can continue with sport-specific drills, plyometrics, everything that you would typically do from a rehab standpoint for months after the injury, and that's okay.
Someone who's re-ruptured, have you leaned more towards doing the same like operative, or have you seen it where they then choose to go non-operative?
Yeah, I unfortunately have had a number of re-ruptures, and pretty equally both after non-operative and after surgery. So in my experience, at least, there hasn't been a clear advantage in one realm or the other. And I've managed, in all honesty, the re-ruptures in every single way. I've gone back and revised them, either using the same approach or using an open approach from starting from a minimally invasive approach. I've non-op re-ruptures, and almost universally patients do okay. I think recognizing that it may not be the outcome we entirely desired, but for most patients and most, at least recreational athletes, getting 80% of your functional strength, power, endurance back with your Achilles tendon allows you to do most things pretty well. It's in those, more elite or professional athletes where that extra percentage of strength really makes a difference. In those patients, I'll tend to discuss, going ahead and doing a revision surgery, and really trying to augment that strength as much as possible.
Yeah, I'd agree for sure.
So you did kind of mention about another surgery possibly to help with that strength. Is there would that be augmenting the tendon?
Yeah, so one potential option, even in the primary setting, is transferring a tendon that's nearby to the Achilles. That's the tendon to the flexor hallucis longus, which is the tendon that plantar flexes the great toe. It runs right next to the tendon, and so it's really easy to both identify the tendon and transfer it either to the Achilles tendon substance itself or to the calcaneus. And you may ask, well, can I bring my big toe down afterwards? And it turns out there's intertendinous connections with other tendons that help to plantar flex the great toe. So most people don't notice any significant weakness with great toe plantar flexion. But it's certainly an option, getting that extra percentage of strength either in the primary setting or, at least in my hands, I try to save it for that revision scenario where the patient's either re-ruptured, or in patients who have more chronic ruptures. I think it's a great option in those kind of salvage cases.
That's pretty cool. That's interesting. I haven't heard that one.
Mm-mm.
Yeah, definitely. That's more of a, if you're looking at those chronic type of situations where there's maybe a big tendon gap or something like that, that you're considering augmenting or doing that tendon transfer. But it in the primary, like Achilles tendon rupture, the one kind of that we're most familiar with, there's not a role for that in the acute setting. It's more for like these salvage type situations.
Got
Just
it.
to clarify.
I will disagree slightly with that, in saying we had talked earlier about tendinopathy. If I see a patient with really florid tendinopathy on an MRI, their tendon is super thick, I think that's a diseased tendon. It tore for a reason. It might tear again. And so for those patients, I'll consider doing that tendon transfer from the get-go.
Yeah, so maybe identifying someone who had some pre-existing tendinopathy. So what, to ask you a question, like what are you seeing on physical exam that kind of led you to that? Were you getting an MRI, or did you feel the tendon itself, or how did you come up to like, I'm going to maybe consider an FHL transfer on your Achilles tendon rupture?
Yeah. I routinely get an MRI on every Achilles rupture. I think it benefits you from a medical legal standpoint, in terms of confirming the diagnosis. But I think it helps you identify those kinds of instances where you see severe tendinopathy or you see something you weren't expecting. a partial tear, for instance, that kind of masqueraded as a full thickness tear. I think you can see that much better in an MRI. It's not mandatory to get one, certainly before proceeding with surgery, but I do think it can be beneficial in identifying those kind of more occult cases.
Yeah, I think for me, if the story is kind of like it would happen during sport or activity, and there's a clear identified, like, this is the etiology of it. Maybe there was no pre-existing tendinopathy, and I have all my physical exam signs. I'm not getting an MRI. I just get an X-ray, because you have to have an baseline X-ray. You will be surprised on those kind of things, but I can pretty much say, like, with a lot of certainty through my physical exam and the other things, like, this is a mid-substance tear, and I basically in the clinical exam room, I'm seeing, can I feel the gap? Can I feel the proximal end? Can I feel the distal end? Am I going to be able to repair this? If there's something weird going on, that's when I'm like, okay, let's back up, let's take a pause, and then let's get an MRI to see what's really going on there. And then that's when you might be surprised.
I don't mean to take over this conversation, but now I kind of have to bounce back at you. So, have you ever been surprised, though, when you get in, you haven't got an MRI, that this is kind of a higher rupture, kind of more proximal to the musculotendinous junction than kind of you were expecting based on your pre-op exam?
Yeah, I think earlier on, I did have a situation where it was higher than expected. And then that definitely was a little bit of a surprise, but it's not something that I couldn't manage in the operating room, but it is definitely something I wish I had known, that it was a higher rupture. But now I think that, understanding that and like retrospectively looking at it now, the way that I do my examinations, I can pretty much, if I cannot clearly palpate that proximal end, then I'm going to consider getting an MRI just to make sure that it's not really a musculotendinous kind of situation, and it is truly just a mid-substance that's a little bit retracted or whatever it is.
Interesting. That's really cool.
It's really fascinating to hear you guys like go back and forth on that. I know Randy and I are completely different clinicians as well, so sometimes we have our differences and ideas of how we treat things. So it's pretty cool to see it from a physician perspective as well.
There's so many different ways to even do this surgery that we do a different, essentially a different technique, right? How are you doing it?
Yeah, I just do a minimally invasive end-to-end repair.
Okay. So I do a minimally invasive, I take the proximal end, put it into the calcaneus, still minimally invasive, but just a different way of doing it.
Well, I think that's cool too, because it provides more options. So when we have patients kind of trying to examine their options, it's really cool to kind of hear what's out there, what works for what surgeons. That's really awesome to hear.
Yeah.
So going on the more later end of a rehab process, and hopefully to that, getting to the return to play aspect, what do you guys look for before making that return to play decision?
I think it's a challenging kind of time point in an athlete's rehab. I think the important thing to recognize is it oftentimes doesn't have to be a single time point. I think play can be defined in a number of ways. And so not every athlete has to go back to full 100%, active, high level of play. It may just mean starting off with some drills, progressing in practice, and then eventually, competing in a game. I think if at least some guidelines, if a patient can do 10 single limb heel rises, I think they've gotten the vast majority of their strength back. They should feel pretty ready to return to play. If they're able to repetitively jump symmetrically without compensation, I think that's another factor I assess for. But oftentimes, after month 6, if a patient can do a single limb heel rise, I say, hey, when you're ready, go for it. I don't have a strict guideline in terms of both time or specific exam maneuvers or testing. I think sometimes, most of the time, an athlete can tell based on what they're feeling if they're ready to go back to their previous level of play.
I would say I rely on therapists and athletic trainers to kind of guide that decision. There's after a certain point, we're past the re-rupture, maybe the complication, and the tendon is healed. It's just whether or not, like Brandon was saying, that return to play, there's no strict, like, this is the time. there's a lot of different factors and decisions that need to be made, and whether or not that that person can return safely, to their sport without incurring some other injury or something like that. There's so many different factors that come to it, but it's definitely nuanced. There are, there's metrics out there to kind of say like how much strength do they have relative. I would just go like, if they have very similar strength to their contralateral unaffected side, then and they're able to do their maneuvers safely, then in conjunction with the approval of the trainers and physical therapists, I think that's appropriate.
Yeah, I think the key thing is understanding the real time point where the tendon's at risk for rupture is, again, kind of that transition from boot to shoe. Past month 3, you're not really worried about, I shouldn't say 0% chance of a re-rupture. It's certainly still a possibility, but the risk goes way down. And so as a result, it's really, again, a discussion, assessing the athlete, and understanding what their needs are for their ankle in terms of their specific sport, more so than a specific timeline or specific metric.
For sure.
And I think as we go along, we're trying to get away from timelines as well. I think it's definitely more individualized, as you see, per person. And like you guys are saying, like functionally really looking at and what their sport demands are, because it's going to be a lot different for someone who's jumping a lot versus someone who might not be.
Yeah. You're going to have a different, for a cyclist versus a,
oh, definitely.
Versus a gymnast. Like they're just going to have totally different needs. So yeah, it's a spectrum.
Yeah. And I would say your role in this phase is, I think, even more important than our role. Oftentimes I'm seeing these patients back every 2 or 3 months, and it's a kind of a quick 5 or 10 minute cheerleading visit. But again, you guys are the ones that are seeing these athletes every day or every few days, really assessing their abilities and their sports capacity. So like Justin said, I rely on your opinions just as much as my opinion. So certainly recognizing your influence in that decision and kind of advocating for your patient, I think, is critical.
Yeah, great collaboration goes a far way.
Yeah, absolutely.
Yeah.
All right, so on that note, ready for your action item?
We're so ready.
All right, go for it.
So here on AT Corner, we like to finish up with an action item, something that athletic trainers can take into their practice today. So just to kind of wrap it up, briefly, could you tell us what advice you would give an athletic trainer who is rehabilitating an Achilles repair for the first time?
I would say understand that this is going to be a process both for you and the patient. Understands that there's a biology aspect to this too. Again, the tendon begins with a phase of early healing tissue that has to remodel, and that process takes time. It can't always be accelerated, no matter how hard we try. So just understanding that it's going to be a process. Don't worry so much about timelines. You may get a functional rehabilitation protocol from your surgeon, or from the physician that's taking care of the patient. Again, recognize that not every little line item in that protocol needs to be met at the exact week. Again, listen to your patient, trust your instinct, keep the athlete engaged. Again, this is an emotional trauma for the athlete. Being able to kind of give them encouragement throughout the whole process really makes it a much better process for the athlete to go through. So recognize there's an emotional aspect, a physical aspect, and you'll get better as time goes on. It's not necessarily something that you have to have the answer to right away. This is an injury that benefits from experience.
Yeah. First time, it's definitely going to be daunting, just like in everything. But the things to look out for are, protect the repair early on. And then slowly, once you gain that mobility back, then you can start doing the loading. And the tendon really benefits from loading, and so progressive strengthening. There's all sorts of different ways to do that, but communication and collaboration with your team and with therapists, trainers, surgeons, particularly early on, is going to benefit that person. So if you notice anything weird, for instance, like, all of a sudden they've got more motion than they did like 2 days ago, then maybe that might be something to bring up. Or, hey, something's not looking right with this wound. Maybe we need to get this looked at earlier. These are the kind of things to kind of counsel early kind of, providers or practitioners, like, hey, this, if it doesn't look right, just bring it up. And then through that, experience of seeing these things, and maybe it's nothing, you're going to learn a lot more. And basically gain that experience that you eventually will need to kind of take care of these injuries. But yeah, definitely recognizing the emotional kind of aspect of this. It's unfortunately just one of those things that requires a lot of time. And sometimes it's like, we just want to get them back early, but sometimes a little bit slower is going to be better. And that's going to be kind of just like tempering expectations and just getting them through it. But obviously the work that, you guys do and that physical therapists do is absolutely crucial for this, for the long-term result. Like, we're the mechanics putting it together, but like, this is the rehabilitation is absolutely crucial, really. And I think that's what it all boils down to.
Awesome. Sweet.
Yeah.
Yeah. Thanks, guys. This was awesome.
Yeah. Thank you so much.
Thank you.
Thank you. Thanks for having us.
I did have
Thank you.
a question about swelling. How much swelling should we be expecting throughout rehab? Like, should it kind of taper off in the beginning? Or I know some joints, especially like the knee, you see swelling come back and that's a little more worrisome. But Achilles, are you really only supposed to be seeing that in the beginning of treatment, or is it more worrisome if that comes back?
I find Achilles ruptures, they don't swell as much as I would expect them to. Sometimes we often have to delay some surgeries after an injury because of swelling. I don't have to do that frequently with Achilles ruptures. So for me, as long as the wound is intact, it's not breaking down because of the swelling, I don't get too worked up about the swelling after this type of injury. That said, it should taper down over the course of the first 4 to 6 weeks after the injury or after the surgery. But recognizing that some element of swelling can be normal even up to a year after the injury.
Yeah, usually you'll get that acute swelling, like you'll get the acute swelling from the injury, and then sometimes you get a ton of bruising. That's like, can be kind of scary for the patient. That's all normal. That'll go away with some time. And then generally after the surgery, when it's being immobilized for that first 6 weeks, when not much is going on, it'll kind of go back down. And then once you start the rehabilitation, it's going to come back again. But in comparison to other things in the foot and ankle, it's not the same type of swelling. So I generally find that just over time it improves. And it's not abnormal, but there's not something specific to say like, oh, something is wrong if there is some swelling. Like, usually it'll be okay.
Oh, that's good.
Cool.
I did have a question on what you guys' thoughts were on, not specifically, I guess, not Achilles rupture, but I've had some physicians in support or not in support of using instrument-assisted tools on the Achilles tendon. What are your guys' thoughts on, like, just in a tendinopathy, if you have any specifics on IASTM?
I mean, I personally, I don't have any kind of restrictions once the wound is healed in terms of like what you can and cannot do to assist, whether that even be through like manual kind of, therapy or like scar, like, are we talking about like scar rehabilitation, like scar massage and that kind of thing? Or what are we specifically talking about?
I've had physicians who prefer IASTM just for like tendinopathy, like Achilles tendinopathy, just going back and forth over that tendon. But I've also had some physicians who have said that they don't it just irritates the tendon sheath. So I was just wondering what your guys.
I think there's probably, a balance with it, and it can certainly be overdone. I think, as with any kind of modality, as long as it's done balanced and not over aggressively, I think it can respect the biology and respect the tissue. I agree. I've had some patients come back and they complain that it's it's a little bit overdone. And so I think in those instances, you'll see the patient hopefully will give you some feedback. And I think encouraging kind of patient feedback, you'll hear about that early on. But there are certainly many modalities, stim, blood flow restrictions even kind of been reported in treatment after Achilles tendon ruptures. So there's a lot of modalities. Like Justin, I think I kind of leave it in the hands of the trainer, the therapist, and their expertise in terms of managing the patient's post-op rehab in that respect, as long as, again, the wound is healed and we're not too aggressive and hurt the patient.
Yeah,
for sure.
Sweet.
Yeah.
Sweet. Yeah. This is awesome.
Yeah. Thank you so much, guys. I think the first time you see an Achilles rupture is so trippy.
Yeah. No, it definitely is. Like, even because, again, like when you're in school, you're taught like, oh, it's kind of like it tends to happen more in like the weekend warrior kind of athlete. But like mine was in a like 18, 19-year-old collegiate athlete.
Yeah,
so it is trippy.
Mine.
Yeah.
And like literally textbook, the way they say it, it's like he literally thought someone kicked him.
Yeah. Yeah. Mine was a pole vaulter, and like no one's around you on the runway, and felt like someone like kicked her.
Right.
But kind of what you said in kind of like the beginning of this episode about like kind of like the two different, or like the two takes on the surgery. It was really nice to hear that in conversation. Like even like two surgeons, same specialty, right? We're talking about the same thing, just kind of different ways to approach the problem and like how they kind of do their practice. And like, it's something that's like very interesting to hear, and like really why you want to really kind of get to know the surgeon that you're working with to see, hey, what do they prefer and why?
Yeah, I think that's something unique that we haven't really gotten as much from this podcast as far as like a surgical series. I really, really loved hearing that two perspective, like I was saying before, because there are just so many ways that you can approach it. And rarely is there a time that you can really put a blanket statement in medicine.
Yeah, no, for sure. And I think this episode was a good representation of that. And just the art of medicine too. I think it really helped kind of show that.
Absolutely. So we do have other episodes other than our surgical series and interviews. Here on AT Corner, we provide athletic trainers with continuing education units. So if you're interested in those, as it is almost reporting time.
Yes.
We are sub 2 weeks away from this reporting cycle. So if you're looking for some CUs, we have a bunch of free CUs as well as some paid ones that go to support not only the show, but also donating cold tubs to athletic trainers. We have those. There's a whole catalog of episodes you can look through. Thank you so much to Clinically Pressed and Athletic Training Chat. We are so grateful to UCI Health for sending over some physicians for the surgical series. As we continue to work with them is super exciting. We also do story episodes where we bring stories on highlight topics from different athletic trainers around the world, and we synthesize them, bring them together, and talk about that topic and see how, again, multiple perspectives approach one topic. So I think that's all I have. Is that all?
Yep. Yeah. That was perfect. Thank you for helping us showcase athletic training behind the tape. Bye.